Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Understanding the broad class of drugs known as anxiolytics, sedatives, and hypnotics is a crucial component of pharmacy education. These medications are widely used in clinical practice for various therapeutic purposes, including the treatment of anxiety disorders, substance withdrawal, seizure management, and insomnia. Their significance is also underscored by their diverse mechanisms of action and significant toxicity profiles. These drugs are defined by their ability to reduce excitability in the nervous system, which can produce sedation or induce drowsiness and sleep, known as hypnosis. This category encompasses different classes of drugs, such as benzodiazepines, barbiturates, drugs similar to benzodiazepines often referred to as Z-drugs, and other agents that operate via distinct mechanisms. A thorough understanding of anxiolytics, sedatives, and hypnotics is essential for pharmacists and other healthcare providers. This knowledge helps ensure the safe and effective use of these agents, especially considering their common use, potential for abuse, and the withdrawal syndromes that can occur. These drugs are frequently encountered in clinical settings due to their therapeutic applications and the need to manage their risks, including toxicity and withdrawal challenges. This content presents 10 brief learning objectives aimed at highlighting critical knowledge related to anxiolytics, sedatives, and hypnotics. First, learners should be able to define these classes of drugs and explain their fundamental effects on the central nervous system, including sedation and hypnosis. Additionally, it is important to identify the major categories of these agents, such as benzodiazepines, barbiturates, drugs similar to benzodiazepines, and other specific agents, along with key examples within each class. Understanding the primary mechanism of action for most of these drugs involves examining how they interact with gamma-aminobutyric acid type A-mediated chloride channels and the role of specific receptor subunits in mediating their clinical effects. Learners should also be able to differentiate the unique mechanisms of action of special agents such as melatonin receptor agonists like rameltein, orexin receptor antagonists such as suvorexant, and alpha-2 adrenergic receptor agonists like dexmedetomidine. Recognizing the diverse therapeutic indications for these drugs is essential, as they are used to treat conditions ranging from anxiety and seizure disorders to anesthesia induction and insomnia. Moreover, it is crucial to evaluate the significant abuse potential and risks associated with these agents, especially the increased risk of death when they are co-prescribed with other respiratory depressants. The historical impact of barbiturates highlights the importance of this understanding. An important aspect of these medications is their potential to cause tolerance and withdrawal syndromes. Learners should be able to explain the pathophysiology behind these phenomena, including pharmacodynamic and pharmacokinetic changes, and recognize the life-threatening nature of acute withdrawal. Furthermore, an understanding of the characteristics of drug toxicity is necessary. This includes central nervous system depression, abuse potential, pharmacodynamic tolerance, and cross-tolerance among different agents. The principles of overdose management should also be understood. In cases of overdose, supportive care focusing on airway, breathing, and circulation is vital. Additionally, gastrointestinal decontamination strategies, such as the administration of multiple-dose activated charcoal, are important, especially in overdoses involving barbiturates. Finally, learners should critically assess the role and risks associated with the use of specific agents like flumazenil, a competitive gamma-aminobutyric acid type A antagonist. It is essential to understand its mechanism of action and the significant precautions necessary during its use, including the risk of triggering seizures and withdrawal syndromes. Understanding the broad group of drugs known as anxiolytics, sedatives, and hypnotics is essential in pharmacy education. These medications are widely used and exhibit a variety of mechanisms along with significant toxicity profiles. They are characterized by their ability to reduce excitability in the nervous system, which results in calming effects or sedation. When they induce drowsiness or sleep, this is referred to as hypnosis. Anxiolytics, which are often prescribed for their calming and sleep-inducing properties, are a major part of this extensive group of drugs. Indications for the use of anesthetic and sedative drugs encompass a wide range of medical conditions. These medications are primarily prescribed to induce anxiety relief and sedation in patients. They are commonly used to treat anxiety disorders and agitation, as well as to manage substance abuse and withdrawal syndromes, especially from alcohol and other drugs that activate GABA receptors. Additionally, these drugs help in inducing amnesia for patients undergoing uncomfortable medical procedures. They are also utilized in the management of seizure disorders, with examples including phenobarbital and clonazepam, and in the treatment of migraine headaches, such as those caused by butalbital. Furthermore, anesthetic agents like methotrexate, propofol, and etomidate are used to induce and maintain anesthesia during surgical operations. The group includes various classes of drugs and specific agents within each class. Benzodiazepines such as diazepam, alprazolam, lorazepam, chlordiazepoxide, and clonazepam are among the most widely prescribed types of medication globally. Another group includes drugs similar to benzodiazepines, often referred to as Z-drugs, such as zolpidem, Zaleplon, and esopicolone. Barbiturates, including phenobarbital, butalbital, pentobarbital, and methotrexate, form another category. There are also drugs similar to barbiturates like meprobamate. Beyond these, there are newer and specialized medications that work through distinct mechanisms. For example, dexmedetomidine is a centrally acting alpha-2 adrenergic receptor agonist, while propofol functions as a GABA-A receptor agonist and NMDA receptor antagonist. Furthermore, medications like rameltein and tasimeltein activate melatonin receptors, helping regulate sleep-wake cycles. Suvorexant is another drug that blocks orexin receptors, which are involved in wakefulness. Chloral hydrate, an older hypnotic, has an active metabolite that acts as a GABA-A chloride channel agonist. There are also less commonly used sedative hypnotics such as glutathione, ethchlorvanol, meprobamate, and methaqualone. Although their use has declined significantly within the United States, some of these medications remain available in other countries and hold historical significance due to their association with abuse and poisoning. In the field of pharmacology, agents such as anxiolytics, sedatives, and hypnotics form a diverse group of drugs that healthcare providers frequently encounter. These medications are primarily used to reduce anxiety and induce sedation, which often results in drowsiness or sleep. They are commonly prescribed for various medical indications. Fundamentally, these drugs work by limiting neuronal excitability to produce sedation and facilitate sleep, also known as hypnosis. This mechanism helps in managing conditions that require calming effects or sleep induction. However, their use must be carefully monitored due to potential toxicity and the risk of withdrawal syndromes. Most sedative hypnotic drugs that are effective in clinical settings work by enhancing the function of chloride channels mediated by gamma-aminobutyric acid, a principal inhibitory neurotransmitter in the brain. These drugs achieve this effect by binding to specific sites on the gamma-aminobutyric acid type A receptor. When they bind to these sites, they facilitate the binding of gamma-aminobutyric acid to its receptor. This facilitated binding increases the influx of negatively charged chloride ions into the neuron. The increased influx causes the neuron to become hyperpolarized, which means it is less likely to fire electrical impulses. As a result, neuronal activity is suppressed, leading to sedative and hypnotic effects. The gamma-aminobutyric acid type A, GABA-A, receptor is a pentameric structure composed of various polypeptide subunits such as alpha, beta, and gamma. Different combinations of these subunits influence the receptor's drug selectivity and its clinical effects, which include sedation, reducing anxiety, inducing sleep, amnesia, and relaxing muscles. Most sedative and sleep-inducing drugs bind to GABA-A receptors that contain the alpha-1 subunit. This particular subunit is mainly responsible for producing sedative and memory-impairing effects. The alpha-2 and alpha-3 subunits are associated with reducing anxiety. The gamma-2 subunit is essential for benzodiazepine drugs to exert their effects. Some non-benzodiazepine sedative hypnotic medications, such as zolpidem, Zaleplon, and Zopiclone, selectively target the alpha-1 subunit. This selective binding explains their primary hypnotic effects, with less impact on anxiety at effective doses. In contrast, GABA-A receptors that contain alpha-4 and alpha-6 subunits tend to be insensitive to benzodiazepine drugs. Beyond the GABA-A receptor, some sleep agents have additional or alternative mechanisms of action. For example, certain drugs such as trichloroethanol, which is the active metabolite of chloral hydrate, and propofol can inhibit N-methyl D-aspartate receptors. These receptors are involved in excitatory neurotransmission, and their inhibition contributes further to the depression of the central nervous system. Some benzodiazepines are capable of inhibiting the presynaptic uptake of adenosine, a substance that typically exerts a negative modulatory effect on the release of glutamate, an excitatory neurotransmitter in the central nervous system. This inhibition can enhance sedative effects. Newer sleep aids such as Rameltian and Tasimeltian act as agonists at melatonin receptors, specifically in the suprachiasmatic nucleus of the brain. These receptors play a crucial role in regulating sleep length and reducing the time it takes to fall asleep. Dexmedetomidine, a drug that centrally acts as an alpha-2 adrenergic receptor agonist, decreases the release of catecholamines. This action leads to sedation and, at higher doses, can cause side effects such as slow heart rate and low blood pressure. Another newer medication, suvorexant, works as an antagonist at orexin receptors in the brain. By blocking these receptors, it inhibits signals that promote wakefulness. Benzodiazepines have a notable history in the development of sedative medications. The introduction of chlordiazepoxide in 1960 marked a significant breakthrough, followed by the release of diazepam in 1963. Both of these drugs quickly became among the most frequently prescribed sedatives worldwide. Their improved safety profile played a crucial role in reducing the risks associated with earlier sedative hypnotics, such as barbiturates. Benzodiazepines work by attaching to a specific site on a type of receptor in the brain known as the gamma-aminobutyric acid type A receptor. When they bind to this receptor, they increase how often chloride channels open in response to the neurotransmitter gamma-aminobutyric acid. This results in more negatively charged chloride ions entering the nerve cells, which inhibits their activity and leads to a calming effect on the nervous system. An important safety feature of benzodiazepines is that, unlike some other sedative drugs, they do not stimulate the GABA channels to open independently at high doses. Different forms of the gamma-aminobutyric acid type, a receptor known as receptor subunit isoforms, are responsible for various effects. For example, the alpha-1 isoform is primarily associated with sedative and sleep-inducing effects, whereas the alpha-2, alpha-3, and alpha-5 isoforms are linked to reducing anxiety and preventing seizures. Examples of common benzodiazepines include various medications used for anxiety, sleep disorders, and sedation. These drugs are known for their calming effects on the brain and central nervous system. Some well-known examples are diazepam, which is marketed under the brand name Valium, and alprazolam, sold as Xanax. Other common medications include chlordiazepoxide, Librium, clonazepam, Klonopin, lorazepam, Ativan, midazolam Versed, oxazepam Cerix, temazepam Restoral, triazolam Halcyon, estazolam Prosom, flurazepam Dalmane, flunitrazepam Rohypnol, and quazepam Doral. These medications are used to treat various conditions, but they should be taken under medical supervision due to potential side effects and dependency risks. The toxicity profile of benzodiazepines indicates that while these medications are widely prescribed, overdoses, particularly when taken alone, rarely lead to life-threatening respiratory or hemodynamic complications. However, the risks significantly increase when benzodiazepines are co-ingested with other central nervous system depressants. This combination can lead to serious adverse outcomes, including death. Additionally, benzodiazepines carry a significant potential for abuse. Chronic use of these drugs can result in a distinctive withdrawal syndrome if they are suddenly discontinued. Barbiturates were first introduced in 1903 and became the main sedative hypnotic drugs during the first half of the 20th century. However, their use was associated with a narrow therapeutic index, which means the range between a therapeutic dose and a toxic dose was very small. This made them potentially dangerous, especially because of their high potential for abuse. As a result, overdoses and suicides involving barbiturates occurred frequently. Due to these risks, the medical community began to seek safer alternatives, leading to the development and adoption of benzodiazepines. These newer drugs offered a safer profile and gradually replaced barbiturates in clinical practice. Current uses of barbiturates, despite their decline, still hold clinical relevance. Phenobarbital and butalbital are employed in the treatment of seizure disorders and migraine headaches, respectively. Phenobarbital is also used to manage moderate to severe withdrawal symptoms from gamma-aminobutyric acid receptor agonists. Additionally, methotrexate is utilized for induction of anesthesia, and pentobarbital is used to control intracranial pressure and treat status epilepticus in intensive care units. The mechanism of action of barbiturates involves inducing sedative and hypnotic effects by enhancing the binding of gamma-aminobutyric acid, commonly known as GABA, to the gamma-aminobutyric acid type A receptor complex. This action increases the duration for which chloride channels within the receptor complex open, leading to an increased flow of chloride ions into neurons. At higher concentrations, barbiturates can directly activate these chloride channels without the need for GABA binding, further contributing to their sedative and hypnotic properties. Examples include several barbiturate medications. Phenobarbital, commonly known by the brand name Luminal, is one of the key examples. Other important medications are butalbital, which is sold under the brand name Fiorinal, and thiopental, known as pentothal. Additionally, methotrexate, marketed as Brevital, and pentobarbital, sold as Nembutal, are notable. Secobarbital or seconal amobarbital, known as Amital, mephobarbital called Mebarol, and Primidone, marketed as Myceline, are also significant examples. Barbiturates carry the highest risk of causing serious illness and death among all sedative and sleep-inducing medications. When someone overdoses on these drugs, it can result in severe depression of the central nervous system, leading to coma, a dangerously low body temperature, and failure of the circulatory system. Long-term use of barbiturates can lead to tolerance, where the body gradually becomes less responsive to the drug, requiring higher doses to achieve the same effect. Additionally, withdrawal from long-term use can be life-threatening. Symptoms of withdrawal include restlessness, feelings of anxiety, trembling, rapid heartbeat, and seizures. These risks highlight the importance of careful medical supervision when using or discontinuing barbiturates. Since 1989, a new class of drugs known as benzodiazepine-like medications has been developed. These agents were created to provide hypnotic effects while potentially causing fewer side effects compared to traditional benzodiazepines. Structurally, these drugs are different from benzodiazepines, yet they bind selectively to a specific part of the brain called the gamma-aminobutyric acid type A alpha-1 subunit at the benzodiazepine receptor site. This selective binding is thought to contribute to their hypnotic effects and may help in reducing unwanted side effects. The receptor selectivity of these medications primarily leads to sedation with a lower potential for anxiolytic or anticonvulsant effects at therapeutic doses. They generally decrease the time it takes to fall asleep and have minimal impact on the overall structure of sleep. The main drugs in this class include zolpidem, also known by its brand name Ambien, Zaleplon, Zopiclone, and Esopiclone. Regarding toxicity, in cases of overdose, these drugs commonly cause drowsiness and depression of the central nervous system. However, it is rare for such overdoses to result in prolonged coma or respiratory depression. Chronic use of these medications can lead to the development of tolerance and a mild withdrawal syndrome upon cessation. This group includes drugs that have largely been replaced by newer and safer alternatives. However, some of these medications retain historical or limited contemporary significance. Chloral hydrate, first introduced in 1869 and historically known as Mickey Finn, is now rarely used. It is occasionally administered, particularly for pediatric sedation. After administration, it is quickly metabolized to trichloroethanol, which is responsible for its hypnotic effects, and to trichloroacetic acid, which is inactive. The toxicity of chloral hydrate is notable because of the production of toxic metabolites. Cardiac arrhythmias represent a major cause of death, and the drug can also cause serious gastrointestinal injuries such as hemorrhage and perforation. Glutathione, marketed as Doriden, was introduced in the mid-1950s. It became well known for its potential for abuse, especially when taken with opioids. Glutathione is structurally similar to phenobarbital and produces comparable sedative and hypnotic effects, although it does not have anticonvulsant properties. It also exhibits strong antimuscarinic activity. Toxicity from glutathione can be complex and may lead to cyclic coma, convulsions, and respiratory failure. Ethclorvanol, also known by the brand name Placidil, was marketed in the 1950s as a hypnotic agent. This drug is highly lipophilic and shares many pharmacological characteristics with barbiturates. In cases of overdose, patients may experience prolonged coma, respiratory failure, and cardiovascular depression. Common complications include pulmonary edema and bullous skin lesions. Meprobamate, introduced in the 1950s, was once widely prescribed until its high potential for addiction and its risk of fatal overdose became apparent. It is the major active metabolite of carisoprodol, which is marketed as Soma. Meprobamate works at the GABA-A receptor in a manner similar to barbiturates and can cause profound low blood pressure due to direct effects on the heart muscle. In the stomach, the drug may form concretions, which can result in delayed and recurrent toxicity. Methaqualone, once sold under the brand name Quaalude, was withdrawn from the United States market in 1983 because of widespread abuse. Its pharmacological properties are similar to those of glutathione and ethclorvanol. Methaqualone toxicity is characterized by coma in combination with hyperactive motor symptoms such as increased muscle tone and myoclonus. There are several special agents and newer medications that act through different mechanisms of action compared to traditional sedative hypnotic drugs. Dexmedetomidine is one such agent and acts as a central alpha-2 adrenergic agonist. Its primary effect is to decrease the release of catecholamines, which results in sedation, a slow heart rate, and low blood pressure when administered in higher doses. Importantly, dexmedetomidine has minimal impact on the gamma-aminobutyric acid type, a GABA-A, receptor, and is not linked to significant respiratory depression. Clinically, it is used for short-term weaning from mechanical ventilation, procedural sedation, and as an adjunct in the management of withdrawal from GABA agonist medications. Propofol is another commonly used agent. It functions primarily as an agonist at the GABA-A receptor and as an antagonist at the N-methyl-D-aspartate NMDA receptor. At high concentrations, it can directly open chloride channels in neurons. Propofol is frequently used as an intravenous anesthetic for both the induction and maintenance of anesthesia, as well as for sedation and treatment of status epilepticus, a severe form of seizure. One serious complication associated with prolonged or high-dose propofol infusion is propofol infusion syndrome, which is characterized by cardiovascular instability, metabolic acidosis, muscle breakdown, and kidney dysfunction. Rameltein is a newer sedative agent that works as an agonist at melatonin receptors, specifically the MT1 and MT2 subtypes. This drug helps to increase the duration of sleep and decrease the time it takes to fall asleep. Rameltein is notable for its low potential for abuse and the lack of a reported withdrawal syndrome. Suvorexant is another recent medication in this class. It works by antagonizing orexin receptors, which inhibits the brain's wakefulness signals. The most common adverse effects of suvorexant are drowsiness and unusual dreams, but there have been no reports of physical dependence or withdrawal symptoms associated with its use. Etomidate is an intravenous non-barbiturate hypnotic agent that is used primarily for the induction of anesthesia. It acts at the GABA-A receptor, specifically at the beta-2 and beta-3 subunits. Etomidate is characterized by its rapid onset and brief duration of action. However, potential toxicities include the accumulation of propylene glycol, which is used as a diluent, and suppression of adrenal gland function. All sedative hypnotic medications produce some degree of central nervous system depression. For many of these agents, the primary mechanism involves enhancing the activity of gamma-aminobutyric acid GABA at the chloride channels by acting as agonists at the GABA type A receptor. When multiple sedative hypnotic drugs or other central nervous system depressants are taken together, their toxic effects can be amplified through both additive and synergistic interactions. These drugs all carry a risk of abuse, and long-term use can lead to the development of pharmacodynamic tolerance. If these medications are suddenly stopped after chronic use, there is a risk of a withdrawal syndrome that can be life-threatening. Cross-tolerance is also common among different sedative hypnotic drugs. Overdoses involving these medications are frequently reported as some of the leading causes of death to poison control centers. Pathophysiology of tolerance and withdrawal. Long-term use of sedative hypnotic agents can lead to the development of tolerance, in which the body requires higher doses to achieve the same therapeutic effect. Tolerance primarily results from pharmacodynamic changes such as the downregulation or desensitization of GABA type A receptors and structural alterations or reduced coupling at the receptor site. Pharmacokinetic factors, such as an increase in the rate of drug metabolism, may also play a role in tolerance development. Cross-tolerance among various sedative hypnotics, including benzodiazepines and barbiturates, is well documented. If these drugs are discontinued abruptly after prolonged use, a withdrawal syndrome can occur that may be life-threatening. Chronic use leads to a decrease in the number or function of neuroinhibitory receptors on cell membranes. Sudden cessation of the drug results in an acute imbalance in central nervous system neurotransmission, favoring excitation and causing hyperactivity. The clinical features of withdrawal are similar across many medications that act as GABA agonists, but the timing and severity of symptoms depend on both the half-life of the drug and the amount that was being used regularly. Although all sedative hypnotic agents produce central nervous system depression, each drug has distinct toxic effects and mechanisms of action. Barbiturates at high concentrations have the unique ability to directly open gamma-aminobutyric acid type GABA-A chloride channels. This is in contrast to benzodiazepines, which only increase the frequency of channel opening when GABA is present. This property of barbiturates makes them more likely to cause severe respiratory and cardiovascular depression. Additionally, barbiturates reduce the excitatory effects of glutamate, inhibit nicotinic neurotransmission, suppress the respiratory center in the medulla, weaken the contraction of the heart muscle, and slow down gastrointestinal function. With prolonged use, barbiturates can induce liver enzymes, leading to increased drug metabolism and pharmacokinetic tolerance. Chloral hydrate exerts its hypnotic and sedative effects primarily through its active metabolite trichloroethanol. Trichloroethanol acts as an indirect agonist at the GABA-A chloride channel, similar to barbiturates. Overdose of chloral hydrate is particularly associated with dangerous effects on the heart, such as making the heart muscle more sensitive to catecholamines, reducing the strength of heart contractions and shortening the refractory period of the cardiac action potential. These changes can result in serious cardiac arrhythmias and cardiovascular collapse. Chloral hydrate is also highly irritating to the gastrointestinal tract, often causing vomiting, bleeding in the stomach, and in severe cases, tissue death or perforation. Benzodiazepines have a notable margin of safety. Even when taken in large amounts, overdoses rarely result in life-threatening respiratory or cardiovascular effects unless combined with other central nervous system depressants. These drugs work by increasing how often the GABA-A chloride channel opens, but they do not directly open the channel at high concentrations. Benzodiazepines are mostly metabolized in the liver, and some have active metabolites that can extend their effects. Propofol acts as both an agonist at the GABA-A receptor and an antagonist at the N-methyldieaspartate NMDA receptor. At high doses, it can directly open chloride channels in nerve cells. Propofol can cause depression of heart function, low blood pressure, and respiratory depression. Prolonged or high-dose infusions may lead to a rare but serious condition known as propofol infusion syndrome. This syndrome is marked by cardiovascular instability, excessive acid in the blood, muscle breakdown, and kidney dysfunction. It is believed that this syndrome is related to disruption of mitochondrial fatty acid metabolism. Furthermore, the soybean oil-based formulation of propofol can support bacterial growth. Meprobamate is another sedative hypnotic agent that can cause significant low blood pressure due to its direct depressive effect on the heart. It can also form solid masses in the stomach, which may lead to unpredictable absorption and prolonged or recurrent toxicity. F-chlorovanol shares many of the same properties as barbiturates. Its toxicity can result in fluid accumulation in the lungs, possibly due to increased permeability of the pulmonary membrane, as well as the appearance of blistering skin lesions and muscle breakdown. Glutathione is structurally similar to phenobarbital and exhibits sedative hypnotic effects like those of barbiturates. It also has strong antimuscarinic properties. The toxicity of glutathione is complicated by its slow and unpredictable absorption and redistribution in the body. This often leads to alternating cycles of coma, seizures, low blood pressure, and respiratory failure, along with fluid accumulation in the lungs and kidney failure. Propylene glycol is commonly used as a diluent in injectable formulations of some benzodiazepines, such as lorazepam and diazepam, as well as etomidate. Prolonged administration of high doses can cause accumulation of propylene glycol in the body. This can result in an excessively acidic state, increased osmolarity of the blood, and elevated levels of lactate. In summary, while all sedative hypnotic agents depress the central nervous system, the details of their therapeutic and toxic effects, including their risks of tolerance, withdrawal, and organ-specific damage, are determined by their molecular actions and how the body processes each drug. Understanding these differences is crucial for safe and effective patient care. Understanding the concepts of tolerance and withdrawal is essential for effective patient management in the context of anxiolytic, sedative, and hypnotic medications. These medications are widely used, but they also carry a potential for misuse. Tolerance and withdrawal are pharmacological phenomena that significantly affect clinical presentation, diagnosis, and treatment strategies for patients who are either acutely or chronically exposed to these agents. Recognizing and understanding these concepts can help healthcare providers better manage the risks and improve patient outcomes. Tolerance refers to the gradual decrease in the effectiveness of a drug with repeated use, which necessitates higher doses to achieve the same therapeutic effects. This adaptive process mainly results from pharmacodynamic changes, such as a reduction or desensitization of neuroinhibitory cell membrane receptors like gamma-aminobutyric acid type A receptors. It can also involve altered coupling of the drug to its receptor site. Additionally, pharmacokinetic tolerance, which involves increased metabolism of the drug after repeated dosing, can contribute to this phenomenon. Cross-tolerance is a common feature among sedative, hypnotic, and alcohol agents. This means that long-term use of one such agent, such as benzodiazepines, can diminish the effectiveness of another, like barbiturates, at their respective binding sites. Withdrawal syndrome occurs when these agents are abruptly discontinued after long-term use. This can lead to a potentially life-threatening clinical state, as it results from a sudden imbalance in the central nervous system's excitatory neurotransmission, which the body has adapted to over time. The general characteristics of acute sedative hypnotic withdrawal have remained consistent since the mid-19th century when chloral hydrate was first introduced. Unlike the relatively mild effects seen in opioid withdrawal, the withdrawal from sedative hypnotic agents can be life-threatening. The course and onset of withdrawal symptoms depend on how quickly the parent drug is eliminated from the body and whether active metabolites are present. For example, withdrawal symptoms from short-acting benzodiazepines may begin within 24 hours, while those from drugs like carisoprodol and meprobamate typically start within 24 to 36 hours. Long-acting benzodiazepines can cause withdrawal symptoms that appear between 4 to 8 days. The symptoms and signs of withdrawal can vary widely, from mild manifestations such as restlessness, tremors, and insomnia, to severe complications including agitated delirium, psychosis, hyperthermia, rapid heartbeat, and seizures. Common autonomic signs include elevated blood pressure, rapid breathing, dilated pupils, and sweating. When diagnosing acute sedative hypnotic withdrawal, it is important to consider both toxicological causes, such as sympathomimetic and methylxanthine toxicity, and non-toxicological conditions like thyrotoxicosis, hypoglycemia, or neuroinfection, as they can present with similar features. Benzodiazepines are among the most widely prescribed classes of medications worldwide. These drugs work by binding to the gamma-aminobutyric acid type, A-GABA-A, receptor in the brain, which increases the frequency with which the chloride channel opens and enhances inhibitory neurotransmission. Tolerance to the sedative effects of benzodiazepines tends to develop more rapidly than tolerance to their anxiety-reducing effects. Chronic use can lead to a decrease in the number of receptors downregulation and a weakening of the connection between the benzodiazepine and GABA-A receptors, functional uncoupling. Withdrawal from benzodiazepines is a common issue affecting nearly 1/3 of people who use these drugs long-term. The symptoms of withdrawal can include instability of the autonomic nervous system, changes in perception, tingling sensations, headaches, tremors, and seizures. Short-acting benzodiazepines such as alprazolam and lorazepam, or those that are eliminated from the body quickly, are associated with more severe withdrawal syndromes and a faster appearance of symptoms. In contrast, benzodiazepines that have active metabolites and longer half-lives, like chlordiazepoxide and diazepam, can delay the onset of withdrawal symptoms. This is due to the gradual tapering effect provided by the persistent presence of these metabolites in the body. Withdrawal may also occur when a person who has been taking a benzodiazepine for a long time is switched to another benzodiazepine that binds to a different subunit of the receptor. The management of acute benzodiazepine withdrawal usually relies on medications that enhance the action of gamma-aminobutyric acid GABA, with diazepam often preferred. Diazepam is chosen for its rapid onset of action, long duration in the body, and the presence of active metabolites, all of which contribute to a prolonged therapeutic effect and a natural tapering as treatment ends. The primary goal of therapy is to control excessive sympathetic nervous system activity and achieve mild sedation, using careful dose adjustments. For long-term management, treatment typically involves tapering the dose of the original drug or substituting with a long-acting alternative such as phenobarbital. Flumazenil, which is a benzodiazepine receptor antagonist, can cause seizures, irregular heart rhythms, and sudden withdrawal. Because of these risks, it is generally not recommended for the management of chronic benzodiazepine toxicity and should not be used indiscriminately. During the early recovery phase, following acute or chronic poisoning with benzodiazepines or similar drugs, it is recommended to restart maintenance doses to prevent withdrawal. Patients recovering from an overdose of sedative hypnotic drugs should be monitored closely for signs of acute withdrawal. Barbiturates were the primary sedative hypnotic medications used during the first half of the 20th century. They were eventually replaced by benzodiazepines because barbiturates have a narrow margin of safety and a high potential for abuse. Barbiturates work by enhancing the binding of gamma-aminobutyric acid GABA to the type A GABA receptor, which increases the duration that the chloride channel remains open. At high concentrations, barbiturates can directly open these chloride channels without the presence of GABA, contributing to their greater risk for toxicity. Tolerance to barbiturates develops through both pharmacokinetic and pharmacodynamic mechanisms. Pharmacokinetic tolerance involves the induction of liver enzymes that metabolize the drug more rapidly, while pharmacodynamic tolerance is related to changes at the receptor level, such as downregulation of the GABA type A receptor. The severity of withdrawal from barbiturates depends on the daily dose used and the degree of dependence. Symptoms of withdrawal usually begin within 24 hours and peak at different times depending on the specific drug's half-life. For short-acting barbiturates, such as secobarbital, withdrawal symptoms peak within 48 to 72 hours. For long-acting barbiturates, such as phenobarbital, symptoms peak around 1 week after discontinuation. Patients may experience restlessness, anxiety, tremors, nausea, abdominal cramps, rapid heartbeat, excessive sweating, and in severe cases, delirium and seizures. The management of barbiturate withdrawal involves gradually reducing the dose of the original medication or substituting it with a cross-tolerant sedative hypnotic. For example, a patient may be switched from a short-acting barbiturate like pentobarbital to a long-acting one like phenobarbital. Benzodiazepines such as diazepam or lorazepam can also be used to control excessive sympathetic nervous system activity during withdrawal. Exposure to barbiturates in the womb can result in newborns displaying withdrawal symptoms starting 4 to 7 days after birth. These symptoms may include excessive activity, restlessness, trouble sleeping, tremors, and instability of blood vessel and heart function. The withdrawal syndrome in newborns may persist for weeks to months. Chloral hydrate is an older sedative hypnotic drug that is metabolized in the body to trichloroethanol, its active form. Trichloroethanol acts as an indirect agonist at the gamma-aminobutyric acid type, a chloride channel. Although physiological tolerance to chloral hydrate after long-term use has only rarely been reported, it is plausible due to its effects on GABA transmission. There is a minimal risk of withdrawal when chloral hydrate is used for short-term medical procedures. Zolpidem, Zalplon, Zopiclone, and Esopiclone are non-benzodiazepine hypnotic drugs. They act mainly by binding to the alpha, 1 subunit of the type A GABA receptor, producing sedation but with less effect on anxiety or seizure activity compared to other drugs in this class. Tolerance to these agents can develop, and abrupt discontinuation after chronic use may lead to a withdrawal syndrome, although it is usually mild. Flumazenil, a benzodiazepine receptor antagonist, can reverse the hypnotic and cognitive effects of these non-benzodiazepine drugs. Since these medications lack substantial antiepileptic properties, flumazenil reversal is considered safer than in cases of benzodiazepine overdose. However, caution is still advised. Rameltein and suvorexant are newer sleep medications with different mechanisms of action. Rameltein acts as an agonist at the melatonin type 1 and type 2 receptors, while suvorexant blocks orexin receptors, thereby inhibiting the brain's wakefulness signals. Both medications are notable for not causing withdrawal syndromes or rebound insomnia, and they generally have a low risk for abuse. A thorough understanding of the diagnostic process for toxicity and withdrawal associated with drugs used to treat anxiety, sedation, and sleep disorders is essential. These substances, which are capable of decreasing excitement levels or inducing sleepiness, are widely prescribed. As a result, healthcare providers frequently encounter cases of overdose and withdrawal related to these medications. The initial step in diagnosing alcohol and sedative hypnotic poisoning or withdrawal involves taking a comprehensive patient history. The clinician should inquire about the medications the patient is currently taking, including the specific dosages and the duration for which these medications have been used. Additionally, it is important to determine which medications the patient had access to in order to gather relevant information for an accurate diagnosis. For an undifferentiated patient in a coma, who has no clear history, routine laboratory screening for drugs of abuse is generally not the most helpful procedure for immediate management. These tests tend to vary in their sensitivity and specificity, and many of the agents associated with alcohol, smoking, and other substances may not be included in standard screening panels. Additionally, the metabolites of these substances may not be detected, which can lead to false negative results. While specific drug testing can be useful for forensic investigations, it rarely influences the initial approach to patient care. Furthermore, measuring the concentrations of specific drugs, such as alcohol or barbiturates, is often unnecessary for real-time clinical decision-making. However, there are some exceptions where such measurements can help guide specific strategies for drug elimination. The clinical presentation of alcoholic sclerosing hepatosis toxicity can often be similar to other conditions, making it difficult to distinguish without specific clues. Benzodiazepines, a class of medications, can have a range of effects depending on the amount taken. Acute and chronic overdose of benzodiazepines may manifest as a spectrum, from mildly decreased sensorium to coma. Symptoms often include impaired psychomotor skills, drowsiness, difficulty speaking, involuntary eye movements, lack of coordination, reduced reflexes, and breathing difficulties. These effects tend to be more severe and last longer in elderly patients due to changes in drug processing and neuropharmacological effects. If respiratory failure occurs, it is a strong indication that another central nervous system depressant or an underlying medical condition is present. Therapeutically, benzodiazepines can cause both retrograde and antegrade amnesia, which can be beneficial during uncomfortable medical procedures. Detecting benzodiazepines in blood and urine samples can be quite challenging. Immunoassays, such as enzyme-multiplied immunoassay techniques, often have limitations in sensitivity and specificity, making accurate identification difficult. More precise analytical methods, like gas chromatography coupled with mass spectrometry, may also face issues when drug concentrations are very low or when metabolites are conjugated. For instance, commonly used benzodiazepines such as lorazepam and clonazepam, as well as those with minimal metabolism like alprazolam and triazolam, may not be detected using standard urine screening methods. Barbiturates are a class of drugs that can cause various symptoms of intoxication. When a person is acutely poisoned by barbiturates, the signs often resemble those caused by other central nervous system depressants such as ethanol or benzodiazepines. Common clinical signs include drowsiness, unsteady movements, slurred speech, and lack of coordination. In milder cases, vital signs and deep tendon reflexes may remain within normal limits. However, as the poisoning becomes more severe, symptoms can worsen to include drowsiness, slowed and shallow breathing, and reduced reflex responses. Laboratory tests are an essential part of initial diagnostics. They should include a fingerstick blood glucose measurement, an electrolyte panel, and a serum creatine phosphokinase test. Additionally, conducting an electrocardiogram is recommended. When a suspected acute overdose is present, screening for acetaminophen and salicylates is advisable. Urine immunoassays are useful for detecting many barbiturates, but they have limitations. False positive results may occur with drugs such as glutathione, and cross-reactivity between different barbiturates, like phenobarbital, can sometimes lead to incorrect readings. Furthermore, gross crystalluria has been reported in cases of primidone toxicity. Serum levels of barbiturates do not always accurately reflect the severity of toxicity, especially in patients who have developed a tolerance to these substances. Nevertheless, measuring these levels can provide useful information about a patient's prognosis or assist in forensic investigations. Typically, concentrations above 35 milligrams per liter for short-acting barbiturates such as secobarbital and above 80 milligrams per liter for long-acting barbiturates like phenobarbital are considered potentially life-threatening. Repeated measurements of serum levels can guide ongoing treatment decisions or help determine if a patient has become brain dead. Chloral hydrate has a distinctive perfume-like odor that can serve as a clinical clue for healthcare providers. This compound is also radiopaque, meaning it can be seen on abdominal X-ray images, which can aid in diagnosis. In terms of laboratory detection, the metabolite trichloroethanol has a long half-life and can be identified in both blood and urine samples, particularly in cases of suspected exposure. However, the parent compound chloral hydrate is rapidly eliminated from the body, which makes testing for it less useful. Furthermore, most hospital laboratories do not have the capability to quickly detect chloral hydrate or its metabolites. Older, less commonly used sedative hypnotic medications include drugs such as glutathione. Although glutathione is not classified as a barbiturate, it shares a structural similarity with phenobarbital. This structural resemblance can cause false positive results on urine immunoassay tests that are designed to detect barbiturates. In addition, there is a concern related to toxicity from propylene glycol, which is used as a diluent. For patients undergoing prolonged infusions of certain medications, such as lorazepam or etomidate, the accumulation of propylene glycol can lead to several adverse effects. These include metabolic acidosis, a hyperosmolar state, and increased lactate levels in the blood. Studies have demonstrated that critically ill patients who receive high doses of lorazepam over extended periods are at risk for significant propylene glycol buildup, which can contribute to these toxic effects. The diagnosis of anxiolytic and sedative hypnotic withdrawal is primarily based on a combination of clinical signs and symptoms observed in a patient with a history of long-term use or abuse of these substances. The clinical presentation can vary significantly. Some symptoms are relatively minor, including restlessness, tremors, and insomnia. However, in more severe cases, symptoms can be life-threatening and include agitation, delirium, psychosis, hyperthermia, abnormal heart rhythms such as tachyarrhythmias, and seizures. Common autonomic signs associated with withdrawal include high blood pressure, rapid breathing, enlarged pupils, and excessive sweating. The overall clinical picture of anxiolytic and sedative hypnotic withdrawal closely resembles that of alcohol withdrawal. The onset and severity of withdrawal symptoms are influenced by the half-life of the drug involved and the amount regularly used. For short-acting benzodiazepines, withdrawal symptoms can begin within 24 hours after abrupt cessation. In the case of carisoprodol or meprobamate, withdrawal may start within 24 to 36 hours. Conversely, for long-acting benzodiazepines, such symptoms can be delayed by 4 to 8 days due to their prolonged half-lives. An agitated patient who exhibits minimal response to increasing doses of a rapidly acting benzodiazepine, such as diazepam, can strongly suggest ongoing withdrawal from sedative or hypnotic substances. Laboratory support for diagnosis is not definitive. However, toxicological testing that reveals the presence of a causative agent or its metabolites can support the diagnosis, although it is important to acknowledge the limitations of such tests. Differential diagnosis for alcohol withdrawal syndrome, AWS, should consider a broad range of conditions, especially given its varied and sometimes severe presentation. It is important to evaluate other causes of central nervous system hyperactivity or autonomic dysfunction. These include sympathomimetic toxicity, which can result from the use of stimulants such as amphetamines or methylxanthines like caffeine. Thyrotoxicosis, a condition caused by excessive thyroid hormone levels, can also mimic some features of alcohol withdrawal. Hypoglycemia, or low blood sugar levels, is another potential cause that may present with similar symptoms. Additionally, neurosepsis, a severe infection of the nervous system, should be considered. Anticholinergic poisoning is also a possibility. However, it often presents with distinguishing features such as absence of sweating and particular neurobehavioral signs, including mumbling speech and repetitive movements, known as carphalogia. When addressing toxicity caused by anxiolytics, sedatives, and hypnotics, a fundamental aspect of pharmacy education is to understand that treatment strategies generally focus on supportive care and careful monitoring. This approach is essential because of the significant risks of central nervous system and respiratory depression associated with these agents. The primary goal in managing an overdose of these medications is to ensure that the airway remains open, the patient receives adequate oxygenation, and that circulatory support is maintained. providing supplemental oxygen and respiratory support are vital components of treatment. In cases of respiratory failure, interventions such as endotracheal intubation and mechanical ventilation may be necessary. It is also important to prevent aspiration, especially in patients who are unconscious. Hemodynamic instability, which often manifests as low blood pressure, should initially be addressed with intravenous fluids to expand blood volume. If low blood pressure persists despite fluid resuscitation, the administration of vasopressors such as norepinephrine may be required. Additionally, severe hypothermia, which is notably common with barbiturate toxicity, demands vigorous rewarming procedures to restore normal body temperature and prevent further complications. Gastrointestinal decontamination involves procedures like activated charcoal and orogastric lavage. The decision to employ these methods is made on a case-by-case basis, carefully weighing their benefits against potential risks, especially the risk of aspiration. Single-dose activated charcoal may be considered if a patient presents within 1 hour of ingestion. However, its effectiveness in altering outcomes is not consistently supported by evidence, and it should be used with caution in patients who do not have airway protection due to the potential for mental status depression. Orogastric lavage might be appropriate for overdoses involving substances that slow gastrointestinal motility or form concretions, such as phenobarbital and meprobamate. Conversely, it is generally not recommended for overdoses of oral benzodiazepines alone, since the benefits are minimal compared to the risks of aspiration. Multiple-dose activated charcoal is an important intervention, especially for certain specific agents. While generally the use of gastrointestinal decontamination procedures requires careful evaluation of the risks and benefits, multiple-dose activated charcoal provides a clear advantage in some cases. This is particularly evident in cases of phenobarbital intoxication. Multiple-dose activated charcoal has been demonstrated to shorten the duration of coma in patients acutely poisoned with phenobarbital. Phenobarbital is a long-acting barbiturate that can cause significant toxicity, making the intervention especially beneficial. Studies have shown that administering multiple doses of activated charcoal can enhance the elimination of phenobarbital by between 50 and 80%, which substantially reduces the drug's serum half-life. One prospective study reported that the serum half-life of phenobarbital was significantly decreased after the administration of multiple-dose activated charcoal, yielding an average of 36 hours with a standard deviation of 13 hours. In comparison, the serum half-life after the use of single-dose activated charcoal was 51 hours with a standard deviation of 52 hours. The use of multiple-dose activated charcoal in cases of severe long-acting barbiturate poisoning is also recommended by the European Toxicology Research and Information Project Workgroup. The mechanism by which multiple-dose activated charcoal enhances phenobarbital elimination involves primarily interrupting the process of enterohepatic recirculation and promoting elimination from systemic circulation. This process is often referred to as gut dialysis. Despite its benefits, administering multiple-dose activated charcoal requires extreme caution due to potential risks, especially in patients with compromised bowel motility and those at risk of aspiration. In patients who are not intubated, there is an increased risk of aspiration if the patient's level of consciousness diminishes during charcoal administration. For patients who are in a coma, airway protective measures such as endotracheal intubation or placement of an orogastric or nasogastric tube are generally necessary to minimize the risk of aspiration when giving this treatment. Additionally, barbiturate toxicity itself can impair bowel motility, which further complicates the administration of activated charcoal. For severe long-acting barbiturate poisoning, the extrapolation of the International Registry for Poisoning (ICSTRIP) workgroup recommends the use of intermittent hemodialysis. It is also important to continue multiple-dose activated charcoal treatment during extracorporeal removal, as this highlights the role of activated charcoal as an adjunctive therapy even when more aggressive elimination techniques are employed. However, there are limitations to these treatments. Multiple-dose activated charcoal and urinary alkalinization are not effective for poisoning with short or medium-acting barbiturates. These agents tend to have higher pKa values, are more bound to proteins, and are mainly metabolized by the liver. As a result, very little unchanged drug is excreted through the kidneys. Additionally, orogastric lavage may be reasonable for certain xenobiotics that slow gastrointestinal motility or form concretions such as phenobarbital and meprobamate. However, this procedure is generally not recommended for overdose involving oral benzodiazepines because the benefits are minimal compared to the risks of aspiration. While flumazenil has the unique ability to counteract the central nervous system depressant effects of benzodiazepines and their analogs, its use must be approached with caution due to its highly selective action and significant associated risks. A thorough understanding of its pharmacology and the clinical considerations is essential when using this medication. The mechanism of action of flumazenil involves acting as a competitive antagonist at the benzodiazepine binding site on gamma-aminobutyric acid type A receptors. When it binds to these sites, it quickly reverses the depressant effects on the central nervous system caused by benzodiazepines. Additionally, flumazenil can reverse the effects of benzodiazepine-like agents such as zolpidem, zaleplon, and esopicolone. These agents exert their effects through central nervous system benzodiazepine receptors, primarily targeting the alpha-1 subunit. Reversing the effects of certain substances is a key application of the medication flumazenil. It can rapidly counteract the central nervous system depressant effects caused by benzodiazepines. These effects include impaired psychomotor skills, excessive sleepiness, difficulty articulating speech, rapid, involuntary eye movements, lack of coordination, reduced reflex responses, and respiratory depression. Additionally, flumazenil is effective in reversing the hypnotic and cognitive effects induced by zolpidem and similar drugs. Despite its ability to reverse critical central nervous system depression, flumazenil must be used selectively and with extreme caution. Its indiscriminate use carries substantial risks. One such risk is the precipitation of withdrawal syndrome. Flumazenil can induce life-threatening benzodiazepine withdrawal in patients who have developed pharmacodynamic tolerance to benzodiazepine receptor agonists, especially in those undergoing chronic benzodiazepine therapy. Another significant risk is the induction of seizures. The use of flumazenil is strongly associated with the occurrence of seizures, particularly in patients who have a history of chronic benzodiazepine use or in those with concomitant intoxication with proconvulsant agents such as tricyclic antidepressants. Reversing the protective anticonvulsant effect of benzodiazepines with flumazenil can unmask the proconvulsant effects of coingestants. Additionally, seizures may occur in patients with an unknown overdose where coingestants cannot be ruled out. Cardiac arrhythmias can be associated with the use of flumazenil. Specifically, in cases of chloral hydrate overdose, while flumazenil may reverse sedation, it can also cause ventricular dysrhythmias by increasing the release of endogenous catecholamines. Consequently, flumazenil should not be used to manage central nervous system depression caused by chloral hydrate overdose. The effects of flumazenil are often shorter than those of many benzodiazepines, which can lead to resedation. This requires careful and prolonged monitoring, even after successful initial reversal. Although continuous infusion of flumazenil has been reported, it is not commonly recommended. Flumazenil has limited efficacy in treating respiratory depression caused by benzodiazepines. Although it can reverse respiratory depression, the extent and duration of its effect may be limited. Consequently, flumazenil is not routinely recommended for managing acute or chronic benzodiazepine toxicity due to the potential risks involved. Scenarios for safer or potential use of medications involve different considerations. In cases of acute, isolated benzodiazepine toxicity, the use of flumazenil is generally regarded as the safest option. This scenario might include young children who have ingested benzodiazepines accidentally, patients who are not undergoing chronic benzodiazepine therapy, or individuals with a low suspicion of coingestion with other substances. Regarding drugs similar to benzodiazepines, such as Z-drugs, it is important to recognize that zolpidem and its congeners do not exhibit significant anticonvulsant effects. Therefore, The reversal of their effects with flumazenol may be considered safer compared to benzodiazepines. Nonetheless, caution remains necessary because these drugs can still cause central nervous system depression. There have been documented cases of death when large amounts of these drugs are taken, especially in combination with other central nervous system depressants. For patients who have recovered from an acute sedative hypnotic overdose, it is recommended to restart maintenance doses of benzodiazepines or drugs similar to benzodiazepines during the early recovery phase. This is particularly important for medications that are rapidly eliminated from the body, as it helps prevent withdrawal symptoms. The overall management of sedative hypnotic overdose mainly involves supportive care, with a focus on maintaining a clear airway, proper breathing, and stable circulation. Antidotes are generally not relied upon in such cases. Instead, attention is given to supportive measures throughout the treatment process. While flumazenol offers a rapid reversal of benzodiazepine-induced CNS depression, its use demands an astute clinical assessment and a cautious approach to avoid potentially severe and life-threatening complications, particularly seizures and withdrawal syndromes. Its role remains highly specialized within the broader context of ASH overdose management. Urinary alkalinization is an effective method to enhance the elimination of phenobarbital through the kidneys. Phenobarbital is a long-acting barbiturate that has a pK value of 7.24. The process involves administering sodium bicarbonate intravenously to keep the urine pH between 7 and 8. This increased pH causes ion trapping of phenobarbital, which prevents it from being reabsorbed in the renal tubules. As a result, the drug is more efficiently cleared from the body. However, it is important to note that this method is not effective for short-acting barbiturates. Hemodialysis and hemoperfusion are effective methods for removing long-acting barbiturates, such as phenobarbital, especially when these substances are less bound to proteins and less soluble in fats. These extracorporeal removal techniques are usually reserved for patients who are severely poisoned and do not respond to supportive measures. They are also employed in cases of renal failure or when serum drug levels continue to increase despite other treatments. Additionally, hemodialysis has demonstrated positive outcomes in cases of severe toxicity caused by chloral hydrate. Monitoring and observation are crucial for patients who have overdosed on sedative hypnotic substances. Continuous assessment of their clinical status is essential. Patients who have overdosed on chloral hydrate should be carefully observed for at least 3 hours, and this monitoring should be extended to 24 hours if signs of toxicity appear. Those who have taken long-acting sedatives or hypnotics, especially those with significant enterohepatic recirculation, such as meprobamate or clonazepam, may require 24 hours of intensive care unit observation. Additionally, serial measurement of drug concentrations, particularly for phenobarbital, can be helpful in guiding therapy during the management of overdose. In the realm of pharmacy education, a thorough understanding of anxiolytics, sedatives, and hypnotics is essential due to their widespread use, diverse mechanisms of action, and significant toxicity. These agents are characterized by their ability to reduce excitability, produce sedation, or induce drowsiness and sleep. Pharmacists and healthcare providers should be familiar with the various categories and mechanisms of these drugs. They include benzodiazepines, barbiturates, benzodiazepine-like drugs commonly known as Z-drugs, and other specialized agents such as dexmedetomidine, propofol, ramelteon, and suvorexant. Most of these drugs work by enhancing the activity of gamma-aminobutyric acid type A receptors, which increases chloride ion influx and suppresses neuronal activity. However, some agents have unique actions. For example, ramelteon acts as a melatonin receptor agonist, suvorexant as an orexin receptor antagonist, and dexmedetomidine as an alpha-2 adrenergic receptor agonist. These drugs are used for a broad range of therapeutic indications, including anxiety, agitation, substance withdrawal syndromes, seizure management, insomnia, and anesthesia induction. A critical aspect to consider is their potential for abuse and toxicity. Although overdoses involving benzodiazepines alone rarely lead to death, fatalities are more common when these drugs are involved in mixed overdoses, particularly with other respiratory depressants. Barbiturates pose the highest risk among sedative hypnotics due to their narrow therapeutic window and their ability to directly open gamma-aminobutyric acid type A chloride channels at high doses, unlike benzodiazepines that only increase the frequency of channel opening. Some agents, such as chloral hydrate, have unique toxicities, including cardiac rhythm disturbances and severe gastrointestinal injuries. Chronic use of anxiolytics, sedatives, and hypnotics often leads to pharmacodynamic tolerance, mainly through downregulation or desensitization of gamma-aminobutyric acid type A receptors. Discontinuing these drugs abruptly can cause a potentially life-threatening withdrawal syndrome characterized by central nervous system hyperactivity. Symptoms may include restlessness, seizures, hyperthermia, and psychosis. The severity and onset of withdrawal symptoms depend on the half-life of the drug and its active metabolites. Unlike opioid withdrawal, withdrawal from these agents can sometimes be fatal. Managing overdoses involves supportive care focused on maintaining airway, breathing, and circulation. This includes providing supplemental oxygen, respiratory support, and hemodynamic stabilization. Multiple-dose activated charcoal can be particularly beneficial in cases of barbiturate intoxication, as it significantly reduces the duration of coma and facilitates the elimination of the drug through the gastrointestinal tract. However, administering activated charcoal requires caution due to risks of aspiration and impairment of bowel motility. The antidote flumazenol, a competitive antagonist at gamma-aminobutyric acid type A receptors, can rapidly counteract benzodiazepine overdose. Nevertheless, its use carries significant risks, including precipitating withdrawal symptoms and seizures, especially in individuals with chronic benzodiazepine use or those who have ingested proconvulsant substances. Consequently, flumazenol is not routinely recommended for all cases and should be used selectively. It is contraindicated in overdoses involving chloral hydrate because it can induce serious heart rhythm disturbances. Flumazenol is considered safest when used in cases of acute benzodiazepine toxicity or for the reversal of benzodiazepine-like drugs. Enhanced elimination techniques, such as urinary alkalinization, can improve the clearance of drugs like barbiturates, and procedures like hemodialysis or hemoperfusion are effective in severe cases involving long-acting barbiturates and chloral hydrate toxicity.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.